bells ringing over the church. In my office, I can hear bells ringing. So good afternoon, everyone, and welcome to our bi-monthly meeting of the Commission to Study Mental and Behavioral Health in Maryland. And let me just go back and maybe there's
recording in progress.
Maybe there's an English major in here, but I always think when you say bi-monthly or bi-weekly, bi means twice. So it sounds like it's twice within the month. So I'll say every other month meeting versus calling it a bi-monthly meeting. And this is our first in-person meeting in about 15 months, 16 months, I think it is the last time we had an in-person meeting. So we can, even though there was a lot of tragedy in the past, I like to try to forget about it, but that's another story. And I think we do. I know I'm rambling right now, but I think most people remember dates based on some kind of landmark, that you did something or seasonal changes. And because we did so little in 2020, unless you were, unfortunately were sick or had a loss in the family or those close to you, it almost becomes erased in terms of that time frame. I know it myself, thinking about when did I do something last or see someone last. Often I say, well, it was just a couple of months ago, but it really was in 2019 because it just had this gap in time. But that's just here and there. Maybe it gets to our mental health issues. But in connection with that, and I guess it does relate, the fact that we didn't have personal communication for 16 months, in-person meetings, in-person activities, it adds to this isolation that many people have felt over the last year and exacerbated challenges that people had, both on the mental health side and also on the substance use side. We'll talk a little bit about the challenges for some of our individuals who are suffering from substance use disorder. Now, it did, though, offer opportunities like we have now to utilize technology and see where we can save in terms of travel and allow more people to participate in events and activities without traipsing down to Annapolis or some other location or spending resources to transport themselves. But again, as I mentioned, at the same time, we have to balance the benefits of this technology with the fact that there is a benefit of that social interaction in person. We are sociable beings, and so that's something that we'll have to address as we move forward. And as I mentioned, the pandemic exacerbated a number of challenges that many of our citizens face with regard to their mental health and challenges with substance use disorder. And many are aware that a large percentage of people who receive treatment for substance use disorder also suffer from mental health issues and seek mental health services. On the substance use side, in 2019, we saw for the first time in many years a decrease in overdose fatalities from alcohol and drugs. However, in 2020, it increased again and increased by 18% in 2020 so far this year, from a year to year, 2020, but between January and March of this year compared to the same period a year ago, it was up 5.7%. So we know that there's been an impact. The isolation, the anxiety has had an impact on those who suffer from substance use disorder. And that's why we launched about a month ago now the Maryland Stop Overdose Strategy, or Maryland SOS, which seeks to leverage new and existing funding and partnerships and experiences of Marylanders to navigate a new chapter in dealing with the opioid crisis. In this fiscal year, We put forward $4 million in grants to support initiatives in each jurisdiction of Maryland to focus on prevention, enforcement, and treatment related to the crisis. And this summer, the Opioid Operational Command Center will begin regional town hall meetings, meeting with local and state partners to hear directly from communities on what's best in terms of approaching this challenge, what works, and actually which approaches don't work as well as we may have thought. Feedback we receive from these town hall meetings will help inform our strategy as we go forward, as we utilize these funds received that we receive from legal action against from the opioid manufacturers. The data collected, will be analyzed by the Department of Health and give us a clear picture in connection with regard to the connection between mental health as well as substance use disorders. The Command Center and the Department of Health are also collaborating, and we'll have a detailed presentation on this in a little bit. Data-informed overdose risk mitigation, or DORM. That analysts utilizing this process will examine the prescription and treatment history of individuals who have died from an overdose, as well as the interactions that these individuals had with the support systems at state and local level. This information will help identify factors that can lead to increased risk of overdose. Dr. Jones, Deputy Secretary of Health, and Mr. James Yo, also from the Department of Health, will walk us through the demographic and behavioral health outcomes for those who have died from opioid overdoses. I just will highlight a couple of the initial findings from the work. That we found individuals who received outpatient mental health services in the public behavioral health system within 30 days before their death were more likely to have also received mental health services, as well as their substance use disorder services. Approximately 70% of the individuals who died from an overdose had an interaction with a Maryland hospital in the 4 years before their death, and 60% of the people who died from an overdose were prescribed a controlled substance at some point in a 5-year period, within a 5-year period. Our hope is that this collaboration will produce new insights, allow us to address gaps in services, and help better engage individuals to save lives. And with that, I'll move to the formal agenda. And as we typically do, we start with going around the table as well as our virtual members and introduce ourselves. So we'll start with the right and work our way down.
I'm Richard Abbott. I'm Director of Juvenile Family Services for the Maryland Judiciary, and I represent the Judiciary.
Roland Butler, Maryland State Police. I represent Jerry Jones.
Senator Addie Eckert, Maryland Senate. I'm from District 37, which is the mid-shore, which is Charlotte, Dorchester, Carolina, and White County.
I'm Marianne Gibson. I'm with the Opioid Operational Command Center, and I'm standing in for our Executive Director, Robin Hart.
Good afternoon, Aaliyah Jones, Deputy Secretary of the Behavioral Health Administration.
Good afternoon, Tiffany Rexford. I'm the Acting Assistant Deputy Secretary of Programs to the Maryland Department of Human Services.
Good afternoon. I'm Delegate Karen Lewis Young. I represent a portion of Frederick County, and I sit on the Health and Government Operations Committee in the House.
Good afternoon. I'm Senator Katie Hester. I represent District 9, which is Howard and Carroll counties, and I sit on the Education, Health, and Environmental Affairs Committee.
Good afternoon, Walter Lee, Department of Education, Director of Student Services, and I'm in for Mary Gable today.
Okay. And we have several members who are coming to us virtually.
Trisha Roddy, Deputy Medicaid Director for the Department of Health.
Good afternoon, Christian Mealy, Deputy Secretary of the Department of Disabilities. Good afternoon, this is Barbara Allen. Let's see, which one will I do? Co-chair of the Behavioral Health Advisory Council.
And a public member.
Good afternoon. Go ahead.
Good afternoon, everyone. This is Dr. Robert Tripolini. I'm an Associate Medical Director for Mid-Atlantic Permanente Medical Group of Kaiser Permanente.
Hi, I'm Kimber Watts. I'm from the Office of the Public Defender.
Joy Hatchett on behalf of Insurance Commissioner Kathleen Brain.
Okay, thank you. I will ask the members if they've had a chance to review the minutes of the May 11th meeting. If they have any questions, comments, or edits. There aren't any. We get a motion to approve.
So moved. Second.
All in favor, say aye.
Aye.
Any opposed? Hearing none. Okay. All right, we'll go to subcommittee reports. The crisis services and Marianne Gibson. As she introduced herself, she's Deputy Director of Operations Command Center and recently appointed staff. So congratulations. And welcome. Thank you.
Thank you so much. Thank you, Lieutenant Governor Rutherford and members of the commission. Happy to be here today. Again, I'm Mary Ann Gibson with the Opioid Operational Command Center, and I'm here on behalf of Robin McCard, who chairs the Crisis Services Subcommittee. Last Wednesday, we hosted our bi-monthly, every other month, Crisis Services Subcommittee meeting. We had 3 informative presentations, the first of which was from Susan Cromwell, Senior Director with the Shepherd Pratt Health System. Our subcommittee learned about Shepherd Pratt's residential crisis services model, which includes a variety of support services such as 24-hour on-site staff assistance, intensive case management, linkage to peer support, and adherence to trauma-informed care. Ms. Cromwell also mentioned that Shepherd Pratt's residential services are co-occurring capable and that 60% of their patient population had been diagnosed with a substance use disorder. Shepherd Pratt's residential crisis services offer on-site support, including prescribing naloxone, maintenance of buprenorphine treatment, linkage to community providers, and on-site recovery support meetings. Next, we were joined by Francis Giroux and Christine Stanley from People Encouraging People, a nonprofit organization that operates both assertive community treatment teams, or ACT teams, and forensic assertive community treatment teams, or FACT teams. Our subcommittee was specifically interested in learning more about FACT teams to better understand how they operate, as this was one of our priority recommendations for the commission last year. People Encouraging People operates in 5 different jurisdictions, including Baltimore City, Baltimore County, Montgomery County, Prince George's County, and Anne Arundel County. Each ACT or FACT team is multidisciplinary and offers mobile evidence-based care for behavioral health conditions. A FACT team is similar in composition to an ACT team, but has a forensic psychology component. Each FACT team consists of 10 to 12 people that work with a wide variety of partners, such as the Public Defender's Office, judges, probation officers, law enforcement, and hospitals. FACT teams are designed to improve clients' behavioral health outcomes and daily functioning, to reduce recidivism by addressing risks that may lead to criminal behavior, diverting individuals in need of treatment away from the criminal justice system, and managing costs by reducing recurring arrests, incarceration, thus increasing public safety. There's currently only one FACT team in the state, which is in Baltimore City, but there are preliminary discussions around expanding these teams statewide. Lastly, we heard from Johns Hopkins University regarding their behavioral health crisis response pilot. The crisis response program was created as part of a recommendation by the Task Force on Student Health and Wellbeing. The goal of this pilot is to assess how the university responds to behavioral health crises among the student population. There has been an increase in mental health crisis calls on campus, and this pilot will pair mental health practitioners with security officers to respond to these behavioral health crisis calls. And they're hoping to launch this pilot program in the Homewood area this fall. And so with that, our next subcommittee meeting is scheduled for September 1st at 10 a.m. And that is our update. Thank you for your time.
doing that, I wonder what other universities are. I would imagine, they're finding that in universities that it's often Dr. Jones is the expert on this, but psychosis often doesn't develop in people until their 20s, late teens. So that college age, you always hear the stories of the child who comes home from college and the parents initially think it's just college did this to them, but there's something else. Christian Mealy, are you going to give update on youth and families?
Yes, good afternoon, Lieutenant Governor, members of the commission. The Youth and Family Subcommittee had its regular meeting yesterday afternoon. We were joined by two presenters, Senator Katie Fry-Hester from Howard County. She provided a legislative update, and Maria Radowski-Stanko, who provided a child and adolescent update on behalf of the Behavioral Health Administration. Senator Fry-Hester's overview focused on the current and available state funding streams used to support Maryland's mental behavioral health system. The senator also gave a summary of SB 299, the Healing MD Trauma Act, an overview of SB 857, the Behavioral Health and Public Safety Center of Excellence legislation, as well as a synopsis of several other pieces of legislation that impact mental behavioral health in Maryland. Maria Radowski-Stanko from BHA discussed the BHA's child and adolescent crisis system updates, and she also reviewed the notice of funding availability for the Adolescent Hospital Overstay Grant Program. So that's something that our subcommittee had begun discussing at some of our recent meetings, and we're looking forward to this NOFA. We feel it's very timely, and we're looking forward to seeing that what work can be done through this stream of grant funding. And then, of course, as you know, our subcommittee has spent much of the year looking at the involuntary commitment and dangerousness standard, and that BHA has been leading an effort to explore this issue through the formation of a stakeholder work group to make policy recommendations. Just recently, the work group issued its draft report, which was disseminated to stakeholders for feedback and comment, and a final report will be circulated by the end of the month. There were three chief recommendations in the draft report, which include clarification of dangerousness, the definition of dangerousness, training for better clarity of the definition, and then data collection and monitoring. At yesterday's subcommittee meeting, we also received an extensive breakdown of each state's dangerousness standard from Dawn Lukey, which she also went over the emergency petition process, sort of like a 50-state survey related to that. And she has a legal intern who is going to be doing a little bit deeper dive into that. So at our next meeting in September, we're going to be reviewing that, as well as discussing among the subcommittee members whether consensus could be reached in terms of supporting some of the findings of the stakeholder work group. So again, our next meeting will be announced soon, but it's usually the Monday preceding the full commission meeting. So that is the next meeting date. So thanks, Lieutenant Governor.
Any questions for youth and family? Should have asked the same thing. Crisis services. Thank you. Trish, are you going to give the update for Tricia Roddy? Are you giving the update for finance and funding?
Yes, absolutely. And I think Joy is here to give the MIA portion of the update. So great news. June 30th of last month, we submitted our Health Choice 1115 waiver renewal application. The renewal application generally allows us to maintain our managed care program under Medicaid. But we added one really exciting new component to our waiver application. Specifically, it allows us to cover institutions for mental disease for adults between the ages of 21 and 65. Again, I think we've talked with with this group before about the federal prohibition that doesn't allow Medicaid to pay for services for adults while they're receiving services in these institutions. We've had waivers over the years. CMS's policy has changed recently. So we, again, are asking CMS to allow us to cover adults in those institutions between 21 and 65. If you remember, we originally asked to cover 2 non-consecutive 30-day stays. We heard from stakeholders, both in this commission work group, as well as other public hearings, that stakeholders wanted us to ask for the flexibilities that other states received, where we cover an average of 30 days for the total program. So we went ahead and made that change to the waiver application. We are hoping that, we are very looking forward to CMS's approval of the application with a January 1st start date. So again, these services would be eligible for a Medicaid payment, hopefully by January 1st of next year. So we'll obviously keep you all posted on the comments and questions that we get from our federal partners around our request. And then secondly, around the system of care, Dr. Jones and others, we've been meeting internally and regrouping to make sure that we have the appropriate goals in place and the work plan in place for the next several months. So we put those meetings on pause to let ourselves regroup and refocus, but we look forward to getting that group back together, hopefully in a month or so. And Joy, did you want to give the MIA update?
Sure, and this will be relatively brief. First of all, we're continuing our work on the mental health parity regulations. And once we finish drafting those, we will have an opportunity for the public to comment. The next major thing that we're working on are the network adequacy meetings. We've had 2 recent meetings, one really focused on basically the standards, the amount of travel distance, the appointment wait times, and things of that nature. That meeting was held back on May the 28th. And then we had a second meeting on June 18th. And that really focused on telehealth utilization, because as you know, because of the pandemic, a whole lot of focus has now shifted toward telehealth and the importance of making that available and making sure that that is considered within the realm of network adequacy. And then the final thing that I want to mention, and I want to make sure that people are aware of, on July the 18th, we're going to be holding a town hall that's going to be focused on credentialing. We have heard a lot of the providers indicate that they have issues and concerns about their ability to get into different carriers' networks and just other issues. So we want to have an opportunity to listen and hear what some of those issues are and see what, if anything, that can be done about those. So once again, that's going to be held on July 18th. And we invite anyone to come in and explain to us the issues and concerns so that we can actually have the opportunity to figure out what, if anything, can be done about those concerns. And that's all from the Insurance Administration.
Any questions for finance and funding? All right. Colonel Butler or Mr. Abbott, or you? Oh, I'm sorry.
That's quite all right.
Senator, I'm sorry about that.
Thank you, Lieutenant Governor, members of the commission. It's great to see everybody in person today.
This is the public safety and judicial system.
Correct. That's good. and I co-chair with Dr. Linda Mineski. So we've had two meetings and continue to follow on the recommendations for the state summit on mental and behavioral health. And some of the leading recommendations had to do with investigating peer support specialists and also the availability of housing. So at our last meeting, we heard from 3 specialists in peer support services: Lori Galloway, the Executive Director of Otter Road in Carroll County, Richard Lewis, a peer support specialist from the Eastern Shore Crisis Response, and Katie Rouse, the Executive Director of Honor on Maryland. And what we learned is that on the individual level, this includes advocating for people in recovery, sharing resources, building skills, building community relationships, and leading recovery groups and monitoring and setting goals. And these peer support specialists operate in 3 settings: in the community through wellness and recovery centers, in clinical settings like outpatient clinics, rehab programs, and inpatient facilities, and in crisis settings. And so our panelists were able to give us a great description of how their peer support services can be utilized in each of these settings, and then stayed on to answer some questions. We're also joined by Jim Hendrick from the Governor's Office of Crime Prevention to give us an update on their efforts to stand up the Behavioral Health and Public Safety Center of Excellence. That was a bill that was passed this year and went into effect. And they're currently, because the CIT Center of Excellence sits in the Governor's office, they're looking at that and implementing the statutory requirements according to that office, and looking at how to structure this Center of Excellence so it meshes really well with the existing CIT Center of Excellence. And so that's ongoing. It's a good update. And then the next step in terms of the grant that we received from SAMHSA will be to implement the Train the Trainers program on the SIM, the sequential intercept model. And so there should be kind of a call for people interested in becoming a trainer coming out this fall. So that's ongoing. Looking ahead to our next meeting, the next topic will be improving housing and accessibility access, which was our kind of number 3 recommendation from the SIM Summit. And our next meeting will be Tuesday, August 10th at 3 p.m. I'll turn it back over to you.
Very good. The peer recovery specialists, are they working both with substance use disorder individuals as well as those in the mental health area?
I believe broadly, yes, but I'm not sure specifically.
They're predominantly found in the substance use disorder space. However, they are also utilized on the mental health side as well. And there's more funding generally for them on the substance use disorder side. And so it's limited usage. Predominantly on the mental health side, you have peer recovery specialists that work with the assertive community treatment programs. All of them have to have a peer that is on the team. That's a requirement for operation. But in general, we would all like to see a greater expansion of peer utilization in other behavioral health treatment environments if there's funding to do so.
So I know that has been brought up in the mental health. I didn't know going around if none of them more with the substance use side.
Yeah, so the advocates, the peer recovery wellness centers, there's a whole peer recovery infrastructure that's predominantly community based, not necessarily attached to programs. So we'd like to see expansion more so into programs to introduce people who don't know about peer recovery supports because their allegiances and they're predominantly working with a program and not necessarily with the community providers, which would be helpful for their transition as they continue to transition through that recovery process.
Okay, now we have a presentation, Dr. Jones, with regard to the data-informed overdose risk mitigation or DORM report, providing an overview of demographic and behavioral health outcomes associated with opioid utilization.
Thank you. So I'll have Dr. James Yo is actually going to be providing the data portion of this conversation and sharing some of the findings of the DORM report. And then we'll together answer questions at the end. But we have a limited amount of time, so I'm giving him more steps.
Well, good afternoon, Lieutenant Governor and members of the Commission. I'm very pleased to be here today to share some of the findings of the data-informed risk mitigation report. It's a mouthful to say. My remarks today will focus on a part of the data around the season to or engage in the public behavioral health system before their death. Being able to match these data sets up, as the Lieutenant Governor spoke to, allows us to do some pre-intensive analyses that we have not been able to do before. So next slide. We're going to be looking at 3 data sources today that were matched up. The Vital Statistics Administration overdose death data, the Public Behavioral Health System Behavioral Health System claims data system, as well as the outcome measurement system, the system that the previous behavioral health ASO managed. And we have various linkages with those data systems, so we can look at decedents across various systems. Next slide. Next. This real quickly, these graphics really show you the trends in behavioral health services. We have seen an increasing trend for both MAUD services and for SUD services overall, about a 20%, over a 20% increase for both services. The next slide that's on the screen really looks at breaking those services down. I won't get into it here, but it looks at it by age group and by racial status. With the age group, what you see is a substantially increasing trend for older adults in terms of engaging with both MAUD and with SUD services.
What's MAUD stand for?
Oh, I'm sorry. It's medication for OUD services. Sort of new terminology. Next slide. So when we're talking about the overdose intoxication deaths, this slide just shows you the trend in overdose deaths. We saw an increasing trend from 2016 to 2017. And then as was discussed earlier, we started seeing a decreasing trend from 17 onward. The red bars are really showing you the percentage of folks who are involved in the behavioral health system. As you can see, in 2019, over half of the over intoxication deaths had some engagement with either mental health or substance use services. And we've seen an increasing trend over time from just about a 72% increase from 37.4% to 56.7%. I will note that the increasing trend really started in 2016, and that's sort of right at the point where fentanyl entered the system. So some of this may be driven by that. Next slide. Next, we looked at the level of engagement of public behavioral health system individuals by looking at those just engaged in mental health services, those engaged in SUD only, and those engaged in both mental health and SUD services. And the rest of my discussion will really be looking at that group. As you can see with this trend, the dual group here that we see both mental health and SUD services experience the highest number of intoxication deaths across all years, and the sharpest rate of increase in deaths, with deaths more than doubling since 2016. In comparison, the deaths among those engaged in SUD services only increased by 46%, and actually those who receive mental health services only actually declined by 19%. Next. This just shows you the population rate, looking at per 1,000 individuals who were engaged with the behavioral health system, and those with the dual mental health and substance use issues were 25 times more likely to die from an overdose than individuals that were active just in the health services realm, and 3.5 times more likely to die than individuals involved in the PDHS system overall. Next. And interestingly, we also wanted to understand their last engagement with the public behavioral health system. So we're looking at, so what is that time between the last engagement with the system and when an individual dies? Now, when we're looking at this by these different engagement groups, you can see here that those who were duly engaged were twice as likely as the other groups that have had a recent service contact within 7 days of their deaths. While those engaged with just mental health or SUD services were much more likely, nearly half of them had a pretty long disengagement with the service system before their death. You can sort of compare that with these, those who had both were more likely to have a more recent engagement with the system. Next. 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 Wanted to look at the service utilization, looking specifically at this group, this dual group again. As you can see here, this looks at both the mental health services and SUD services for this decedent group compared to all other folks in the behavioral health system who also had dual mental health and substance use service use. As you can see here, that there was a substantially different service use with our decedent group. They were more likely to use mental health mental health inpatient services, residential rehab services, and also more likely to use most of the other SUD services, the SUD services. You can see that in every single service, the decedent group were more likely to use services. So they use more services and they use more intense services over time. Next. Okay. Next, we wanted to look at outcomes. It's really the meat of all of this. And when we look at outcomes, this was matching up with the outcome measurement system I talked about before. So still looking at that dual group with both mental health and SUD services, you can see here, this is compared to all other PBHS outpatient services who receive the outcome measurement system data collection. And what you can see here is that this group were more likely to be homeless, more likely to be dissatisfied with their recovery, arrested in the past 6 months or incarcerated, and less likely to be employed as well. And next, we were also able to look at the level of challenge experienced by these individuals by using an assessment tool called Basis 24. And
can I interrupt just one moment? It kind of goes back to the previous start and something that you said, that the decedents tended to use more services over time, both on the mental health and behavioral health side, before overdosing, having a fatal overdose. Sounds like our services aren't working.
I know that's part of it.
I know, I mean, just kind of.
I think that's part of the discussion on what can be done to engage those folks differently, particularly those with dual mental health and substance use issues. I do want to say that this decedent group is far less than 1% of all folks in the public behavioral health.
Right, no, I'm not.
But still,
and it's just the data. That this group, and I know, Dan is here, did a presentation a number of I guess a year ago. 2020 didn't exist. So over a year ago, about the fact that those who suffer from mental health use more acute care services than others, as because of this, the challenges. So these are individuals who have, either one or both comorbidities, are using one of the services, and it's still dying from the overdose. Okay.
Yeah, and I think we can turn it over to questions.
No, it was just at one point, I just wanted to, because I would forget.
Well, I've pretty much gone through the data I wanted to present today, and I think I can turn it over to Dr. Jones or to questions from the committee.
Thank you very much. Yes, I appreciate that presentation. Is there any way to sort out what are true suicide attempts or gestures from this data?
You ask a very good question. And it's a very a difficult question to ask because we don't have really good data that sorts that out. We have suicide data and we have the overdose intoxication data. Sometimes you're absolutely right that there's a portion of those deaths that get reported as overdoses that are suicides. So it's something we are thinking about and trying to figure out how we can nail that down. But if it's not reported, it's hard to.
And then I'm on the suicide commission as well, and we introduced a bill last year to be able to get more definitive data. I know other states have a different way of collecting the data. We could understand if we could, I think, focus in on that so that then maybe it would give us more information on how to design the interventions. Or at least do some more preventive activity.
Certainly having review teams like we do for the opioid.
Right.
It certainly gives a lot more information.
We're trying to figure that out. I know we had brought that bill in kind of based on having.
But it would give us more useful information so that we can make more interventions, to try to prevent more suicides.
We are doing some work to match up the suicide data with the public behavioral health system. So that's sort of one of the first steps.
Do you know how this data compares to other states? Because any differences might lead us back to that question of how does our policy positively or negatively affect outcome?
Another great question. I think that's some of the work to really look at what the data looks like in other states. Again, states are collecting the data in different ways. We have some challenges to really match that up correctly, but I think that's another avenue to sort of look at where we can.
But the general concept, though, that people who have dual diagnoses have worse outcomes is established. The research certainly establishes that. So I don't think that our outcomes are necessarily worse, but again, we don't have any point of reference other than to say, that we have a really good infrastructure for the treatment of behavioral health conditions, including substance use disorders. Not that there's not room for improvement, because there is, but we do have a good infrastructure.
It would be interesting to engage a few states to see if we could do a joint project around this data. But that's probably the only way you're going to sort of get at that, if you want to analyze the same way. Doing sort of a joint cross-state effort.
Thank you. I had a question. I thought there was a slide that looked at the time lapse between the use of the state services and then the subsequent death.
Yes.
Do we have any mechanism for tracking when people stop using the services and like checking in? Like, for example, if it was the average was 2 years after somebody stops using the service, there might be a suicide.
is there any kind of follow-up that we do? That's something that's missing within our public behavioral health system, that's missing in general in healthcare, I would say, is who is responsible for taking care of someone who needs care. Right. And so that is an opportunity that where one of the slides that we didn't talk about, the very last slide, we talked about opportunities. And one of those opportunities is around having, what did I say? It was system of care level care coordination. So tracking and monitoring and following someone as they enter and leave, and when someone leaves care, having that connection to get them, at least to engage them, to try to get them back engaged in services. But that's definitely something that's lacking in our current system.
I would love to talk offline, maybe about pilot program in that area.
Housing. It's not enough to-
Oh, sure. Well, and we had a limited amount of time, so
okay.
I didn't want to overstay, but we have slides on the Behavioral Health Administration's interventions to address a myriad of findings from this report. When we look at the findings in this report, I will say that if you're in the behavioral health space, there's little in these findings that is surprising, because it really talks to the complexity of working with people who have severe, the disease of addiction in its most severe form. And just like any medical condition in its most severe form, there are going to be many people who you will be able to save, to rescue, and then there will be many people who you will not. And so our focus is on looking at those who we are not, in a way that we help improve our system of care, so that we can help even more individuals to be in the category where they can be saved or rescued from their disease. So we talk, there's a lot of training. So there's the statements about dual diagnosis and making sure that people in the mental health space are aware of, are screening for and addressing the addiction needs for those who have comorbid disorder. So we talk on the slide about numerous trainings that the Behavioral Health Administration connects the provider community to help improve and increase their capabilities to manage co-occurring disorders. And then also in terms of what we've also been aggressively doing is increasing the number of people who access evidence-based treatment, of which opioid medications for opioid disorder treatment are. And so I mentioned some of the strategies that we have to do that. And part of that also is going to be capturing the individual who is difficult to capture, and how do you do that? And that, I think, also presents a little bit of a vulnerability and an opportunity to look at the way that our programs are structured is there opportunity, is there the possibility of looking at a more harm reduction approach to treatment, so that people can have full exposure to treatment, but then at the same token, if they're unable to manage the rules and the regulations that we have around our treatment programs, how do you keep them engaged without kicking them out of care? So that's an opportunity that we have. We have lots of programs that try to address homelessness, but of course, that is a multi-agency issue, not just with the Behavioral Health Administration, but we do have many supports to try to address that, because we know that housing is healthcare. And so in order to help as a baseline, people who have any behavioral health condition, but certainly those who have an addiction, helping people to have that housing is very important. And so we mentioned that our MDRN programs and our COC, continuation of care funding for HUD, which gives money to all of the jurisdictions for those who have dual diagnoses and who have housing needs. But then in addition to all those things, there are the needs that we have around system level care coordination, assessing appropriateness of services that are used, improved billing for dual diagnosis services. That's a challenge that we have, and that you can't bill for substance disorder services in a mental health program, or it's challenging to do so in the inverse, billing for mental health services and substance use disorder program, so looking at our billing regs around that, improving collaborative and co-located care to improve access to behavioral health services. And ultimately, what we'd like to get at is using predictive analytics to identify those who are high risk so that we can really tailor the care to the individual who needs it. And that is something that we're looking to do with some of the interventions and projects that have gone forth in the state.
I have questions. Terms for thank you. At this point, we'll turn over to public comment time, and we have a number of people who signed up to make public comments and testify. We'll start with individuals who are in the room, and then we'll go to those who received to talk virtually. And we'll also start with and continue with folks who have not spoken in a long time. And we'll try to get to everyone, but those who have spoken at the very last meeting, we'll get to you if we can. So we'll start with Chris Compton. Made it difficult to get up.
Yeah.
Checking your agility.
Yeah, I'm gonna have to stretch out before I come up here next time. Not in my 20s anymore. Lieutenant Governor, members of the commission, thank you for allowing me the opportunity to come here and speak before you. I was talking to a gentleman when I walked in, and I said, I think the last time I was here, I was in preschool at St. Michael's in our really road trip. It was actually called God's Little People the last time I was here, so it was driving. So thank you for having me here.
Hopefully none of us were here.
So my name is Chris Compton Jr., and I was asked to attend this meeting by my good friend Christian Mealy and offer my testimony as to what has helped me in order to pay it forward and help the next person. I've had at different times in my life battled depression, alcoholism, and addiction. Luckily, my only college roommate, Matt F., has his master's in psychology. I always jokingly say if I had to pay him a retainer, I couldn't afford him. I'm now coming up on 9 years of sobriety. This would not have been possible. Thank you. This would not have been possible without my wife, Lise, Compton, my family, and without the great people at Celebrate Recovery. Men and women of all backgrounds, professions, and regions across the country gather at different times and places during the week to celebrate their steps. They come together to celebrate not only their small victories, but their common understanding of that we all suffer from hurts, habits, or hangups. The motto is a shared meal, usually something home cooked or Chick-fil-A. That's been my experience for the first hour. This helps to build a source of camaraderie along with free coffee and soft drinks. This is followed by a live band singing and giving praise with songs you would typically hear on 95.1 Shine FM. Not sure if you've ever listened to that or not. During the time of live music, in between songs, there's a handout of sobriety chips for amount of times abstinent, along with other connections of Bible verses intertwined along the way. Lengths of time are called out by the leaders of the group, and people approach to accept their chip and are cheered in the process on the way to their accomplishment. What I found to be the most powerful part of this weekly event is the 15 minutes at the end of the music portion where someone provides their testimony before the last song. The first time I arrived, the gentleman stood up in the auditorium and mentioned about everything you can possibly think of he was addicted to during his downward spiral. His story from beginning to end was so powerful that the impact of it made me want to come back again and again and again. After that time, we would break off into any one of 6 to 8 small groups they offered at the time. At my first session in men's addiction group, I had my head down in the back, and the person leading the group said, young man in the back. Yes, you in the back. And I couldn't make this up if I tried. I lifted my head up, and it looked exactly like my grandfather, who I hadn't seen in 27 years. He's been deceased. And he said, you still have your whole life ahead of you. You still have time to get on the right track. We'll do whatever we can to help you. I texted my only roommate, Matt, from college, the one with a master's degree in psychology. And I said, Matt, this is the greatest thing that I think I've ever attended. Luckily, I had Matt F. in my corner, along with my family, my good friends, now my wife, Lise Compton, and our two children, Kaylee and Nev. I realize some people are not as lucky as me. Some people have nothing and nobody to help them. I feel a responsibility now to help the next person. So whether they have someone in their corner or not, I can be there to do what my friend Matt F. did for me. Thanks for letting me share.
What was the name of the program again?
Celebrate Recovery.
Celebrate. Soon, Parsley.
Good afternoon, Lieutenant Governor, members of the work group. I'm Lucienne Parsley from Disability Rights Maryland. We are the Protection and Advocacy Center for Persons with Disabilities for the state. We're here to thank the work group and urge your continued support for people with mental illness and related behavioral health disabilities. We support the recommendations proposed in the report. We urge the work group to proceed carefully as it considers whether and how changes should be made. Specifically, we support the recommendation to promulgate regulations rather than statutory amendment around the definition of danger for involuntary commitment. We believe the goal for emergency involuntary commitment should be protection of the safety of individuals in crisis, as well as the safety of others, and we support the decision to exclude psychiatric deterioration in the proposed definition. We really support the increased use of community-based services, including ACT team services and peer support services, is really critical to engaging people. In our experience, people will be more likely to engage in treatment and services if they are part of that decision to engage in services. We also support the recommendations for widespread training and also for gathering additional data. So we note that the data that was presented by the Office of the Public Defender shows that the vast majority of individuals proposed for involuntary commitment are retained at hearing. That's nearly 10,000 Marylanders per year. The OPD data also indicates that Black Marylanders are more likely to be emergency petitioned for an emergency evaluation, more likely to be retained in hearing compared to white peers. And this disparity mirrors the national data. So Black individuals are on average up to 4 times more likely to receive a schizophrenia diagnosis, even after controlling for other demographic variables, more than twice as likely to be committed to state psychiatric hospitals. We monitor the state psychiatric hospitals for abuse, neglect, and rights violations. So any revision to Maryland's involuntary commitment process must take into consideration these disparities with an eye toward reducing inequities. Thank you.
And Martin.
The Governor, members of the Commission, Dan Martin, the Mental Health Association of Maryland. Thank you very much. It's good to be here back with everybody in person. I appreciate the opportunity to testify, but it has been my first time testifying in public in 1.5 years, so if I'm a little rusty, bear with me. I'm going to speak also to what Lucienne spoke about, which is the Involuntary Commitment Stakeholders Work Group report that was mentioned earlier by Christian Mealy. You know, there was a lot of comments, public comments last time about one particular aspect, a particular component about that report, which is the psychiatric deterioration standard and whether or not that makes sense. And so I wanted to provide a little kind of a different perspective than you heard the last time. But first I want to thank Dr. Jones, thank the Behavioral Health Administration for the inclusive process. That work group process was really inclusive. There are behavioral health providers and professionals, legal rights groups, hospitals, local system managers, individuals with lived experience,
and advocacy organizations for consumers and families were all part of this inclusive process. And I think the results and the recommendations is really a good compromise. You know, no one got everything that they wanted, but everyone had a chance to be heard. We certainly support the calls in the report for increased training and data collection around these issues. And then we have doubts about the need to define danger so specifically. Actually, we think a little bit more discretion is probably advisable. You know, we support that suggested definition again as a compromise, you know, of everyone kind of wanting to do the same thing, support everybody and coming together around some kind of compromise issue. But we do want to thank the Behavioral Health Administration for rejecting in that report inclusion of a psychiatric deterioration standard. We couldn't support such a standard because we think it would subject an overbroad population of Marylanders to involuntary commitment. Just because someone's symptoms may be worsening doesn't make them a danger, nor does it mean that involuntary hospitalization is the appropriate level of care. Predictions of future dangerousness are notoriously unreliable. Studies have shown that clinical assessment of future dangerousness are highly inaccurate. And if mental health professionals would struggle to predict future dangerousness based on psychiatric deterioration, it seems obvious that law enforcement and lay persons who would also be kind of required to apply this standard would certainly perform worse. And so I wanted to kind of wrap up here with something that I don't typically do, but I wanted to make it clear that, so I'm a family member too. And again, I don't typically share my family's story just because I don't feel like I should need to kind of air, our issues, just to have a reasonable debate about policy issues. But I will, because I want to make it clear that there's no one organization, no one group of advocates that speaks for all family members. My sister-in-law has dealt with schizophrenia and worked and battled and lived with schizophrenia for years. It's been really, really challenging for her, for my brother, for all of us. She's been at times, involuntarily committed to the hospital because she's been determined to be a danger to herself or others under the statute, under the standard as it exists currently. But even with medication, just by the nature of her illness, she is literally always at risk for psychiatric deterioration, again, just because of the nature of her illness. And so I can tell you that she would be horrified and scared. We would be horrified and scared if our law allows someone at some point to petition her for involuntary hospitalization against her will, just because they feel that her symptoms are worsening and that she may become a danger to herself because of deterioration. And so, and thank you for letting me share these comments. And Dr. Jones, I look forward to working with you and your team at BHA to kind of the next steps on this report and where we go from here. Thank you.
Thank you, Dan. Thank you very much, and thank you for sharing. I thought when you said you're not used to doing these things and or we're not used to doing this at the end of the presentation, you're going to start singing.
Next time.
So, I always worry about this. Katie Rouse.
Good afternoon, Lieutenant Governor, Commission members, and everyone watching at home. My name is Katie Rouse. I'm the Executive Director of Honor of Maryland. And on behalf of the more than 6,000 people who find support at one of our wellness and recovery centers throughout the state, I just can't tell you how exciting it is to hear you all talk about peer support with passion and to see us as partners and as pioneers in making our system better. Thank you for all of your listening and for really embracing peer support as an important part of our continuum of care. Honor of Maryland participated in that inclusive process with the BHA Involuntary Commitment Stakeholders Work Group, and we strongly support the recommendations of the report, specifically to restrict involuntary treatment to recent, relevant, and reasonable threats to safety, to implement statewide training, and to begin that process of centralized collection and active analysis of the data related to emergency petitions and involuntary hospitalizations, specifically with an equity lens. There is an important difference between bias and noise. When a scale is biased, it consistently over or underestimates weight in the same way every day. If it's noisy, it's unreliable. 3 tries in a row will give you wildly different figures. And as anyone who set a goal weight knows, getting consistent, accurate feedback is critical to your motivation and to your success, especially when you're trying to sustain a long-term commitment to healthy behaviors. Recovery is not that different. It takes concerted effort over time, integrating chosen wellness tools throughout all aspects of your life, and getting ongoing support from a community. Scattershot doses of emergency treatment delivered through a few days hospital stay can save lives, but it has little influence on the precipitating and the perpetuating factors that drive most crisis cycles. But there are ways to integrate and to optimize voluntary choice, even if crisis is part of your cycle, like through a RAP crisis plan or psychiatric advance directives. When it comes to involuntary interventions, we know that our system is far too noisy, and that costs us dearly, whether you measure it in the trauma and disruption experienced by peers and their loved ones, in the continuing disparities for communities of color and marginalized peoples, in officers' overtime for calls that a mobile crisis team could have handled more holistically, or funding inpatient beds instead of ongoing community-based services that prevent and divert crises every day. Without a centralized way to establish expectations and measure outcomes, what we're vulnerable to is biasing our system with potentially calamitous changes based on anecdotes or assumptions that confuse symptoms with safety. Our dedicated behavioral health professionals and our public servants deserve to be properly equipped with the knowledge of the basic precepts, the real harms, the high costs, and the long-term consequences of involuntary practices. Peers already know. Maryland's behavioral health system can't truly consider itself to be trauma-informed and person-centered without addressing these gaps in our protocol and our practices. And so as to the weight of the need to establish a baseline through training and data, the whole working group agreed that this reading was true. So we urge you to adopt the report's recommendations, and thank you so much for your support and your listening.
I don't know if there was anyone else who's here that signed up.
Good afternoon. Oh, can you hear me? I'm Adrienne Bridenstine, Behavioral Health System. Thank you for the opportunity to provide testimony today. For those who are not familiar with us, Behavioral Health System Baltimore is a nonprofit, and we serve as the local behavioral health authority for Baltimore City. So in that role, we oversee the full range of mental health and substance use services. Like my colleagues before me, we too just want to offer our thanks to the Behavioral Health Administration for the inclusive and collaborative process to develop the involuntary commitment report. We were one of the agencies that were also involved with helping to develop the recommendations. So thank you for that process. It is not easy to bring advocates together, passionate advocates together around consensus. But one of the things I do think that all of the advocates agree on is that when involuntary engagement is used, it does represent an opportunity to improve our system of care, and does represent that when people have not been well served by the public behavioral health system. So we offer our strong support for the recommendations that are included in that report. One of the things that as a system manager that we find most valuable are the data elements that we have to look at, which are looking at emergency petitions and then the end result of those emergency petitions where they voluntarily, somebody end up hospitalized. From a systems manager perspective, that is data that we can use to show if we're being more accountable to the people that we're here to serve, and we can look at it at the aggregate and the system level to assess for that. I think it can also provide us an opportunity to look for where there were missed opportunities to better serve those people. So we're really excited to be working on all of the recommendations, but that piece in particular. One of the things that I do think is important to note that it is until now, we still actually don't have access to that data. We look at it sometimes at the local level, but from our perspective, it's unreliable. So we're looking forward to working with the Behavioral Health Administration to put the systems in place to better collect that data. But as we look at policy reform, whether it's at the statutory level or regulatory level, we do think it's important to look at this data, that in particular the data elements that are part of these recommendations before making any type of regulatory change. I think it will inform us as not only for accountability part of ensuring there's better accountability, but informing the decisions we have yet to make. And I think it'll also inform the training recommendation as well. So with that, we just want to say thank you for the opportunity to hear us today. Thank you for the time you put into developing that report.
Thank you. Thank you very much. I'm sorry about that. They're just people having fun, too much fun with the governor. The governor's away, so the mics are playing. So they're having too much fun. Okay, I think we're now going to this will come in virtually.
I'll get to it.
Okay. Okay, Jennifer Mears. See online. Okay. Stephanie Franklin.
Good afternoon, Lieutenant Governor Boyd. Good afternoon, Commission. Thank you very much for allowing me to speak today on behalf of one of the most vulnerable populations in this state, and that is foster care children. My name is Stephanie Franklin, and I am President and CEO of the Franklin Law Group, and we are a child advocacy law firm that has provided legal representation to abused and neglected children across the state of Maryland since 2007. And I am co-counsel along with Mitchell Mervis, who was a partner at Venable LLP. We are co-counsel for the plaintiffs in the LJ versus Masinga federal class action on behalf of approximately 2,300 Baltimore City children and youth. And so we wanted to come here, well, I'm speaking for both Mr. Mervis and I, to talk about some serious concerns we have about this population that needs considerable focus and attention. And three of our concerns center around the following issues: insufficient placement options for foster children and youth with complex behavioral and mental health needs, oversight, program planning, and policy initiatives for foster youth on psychotropic medications, and a lack of coordinated mental health planning, management, and services. So with respect to the insufficiency for placement options for foster children and youth, we have serious concerns about the overstays in the emergency rooms and psychiatric wards. And we do understand that there has been an overstay grant that has been put on the street, a NOFA, but we are concerned that even with that grant being put on the street, that there will still be an insufficient number of beds to meet the demands of this population. And what this does is it places an undue hardship on families and the children, and it disrupts the kids' support systems for their mental and behavioral health stability. There have been some children that have been hospitalized without medical necessity. And as of June 25th, 2021, there have been approximately 12 kids who fit this category. We also have concerns about timely and appropriate clinical and therapeutic care for these children. We also are very concerned with the oversight, program planning, and policy initiatives that I mentioned earlier. We do know that your human services article of the annotated code 8-1102 appointed a state medical director. And in that particular law, there needed to be oversight planning, program planning, implementation of policy initiatives, and practice and policy mandates. But we're not seeing that on the ground level. We're not seeing that at all. And the data that is public under that particular statute indicates that very clearly there is a lack of disaggregation in each of the data points as it relates to demographic information. And there's little analysis to competently address the needs of this vulnerable population and identify their special needs and issues. And even those within that population that may have even more specific issues that need to be addressed. Lastly, we have a serious concern about the lack of coordinated mental health planning, management, and services. So this is what we know. We know nationally 80% of foster care children have mental health issues. And we do not in Maryland have an organized system of oversight, planning, or management of their needs. And what happens with this is that these delays ignite placement disruptions when we don't have these coordinated efforts. And so what that also has shown, what we see across the state, is not only placement disruptions, but access to therapists actually varies statewide, and specifically culturally competent therapists to meet the demands of your most oppressed and marginalized populations, specifically those who are Black and who are descendants of captive and enslaved Africans in the US. And so we also don't have what we call specialized therapeutic services using evidence-based clinical methodologies. It's just not available. We don't have wraparound crises. That's very, very rare. That's been promised over a decade ago, but never delivered. What's unallowable for residential service providers is an unbundling of services to meet children's needs. It's a major, major issue. I spoke earlier about placement disruption, but with placement disruption comes therapist disruption or therapeutic disruption, which makes for ineffective services for this vulnerable population in terms of their therapeutic needs. So this is what we're asking. There's a lot here today that I know you all are looking at and that you're studying, is that we want you to make a special focus and put a special emphasis on the serious, serious needs of these vulnerable children. These are children that some of them are very young, some of them haven't even reached the age of 21. And having a special focus on this commission to study their needs with a specific focus on those who are living on the marginalized edges of the population, the historically oppressed. And I would say specifically, because we know based on several presenters before that, these are Black children and families who are descendants of captive and enslaved Africans in the US. We are asking that you make a special focus on this population in general, and then specifically on race equity in this arena. Thank you.
Thank you very much. One of the subgroups is youth and families, and you can submit any requests through them as well. So I appreciate your testimony. And Gaddis is also coming in virtually.
Yes, hello, can you hear me?
Yes.
Hi, thank you, Lieutenant Governor and Commission members. My name is Ann Gaddis. I'm with the Maryland Coalition of Families, and I'm here to express our support for the recommendations of the Involuntary Commitment Stakeholders Work Group. I'm not going to repeat all the comments that the advocates who preceded me made. They made them well. We agree that psychiatric deterioration should not be included in the definition. We agree on the need for comprehensive training and the collection of data. The only thing I want to add is that we really believe that the process that informed the report was inclusive, thorough, and well-balanced. We especially appreciated the opportunity to present on the personal experience of one family who found that involuntary commitment did not promote the recovery of their loved one, but hindered it. And we want to emphasize that many family members value self-determination and the protection of civil liberties. What they want is for their loved one to have easy access to a wide array of quality, appealing, and readily available mental health treatments and community supports. Thank you for the opportunity to comment.
Thank you. Thank you very much. Brian Stinton.
Yes, thank you, Lieutenant Governor. I'd like to express my disappointment with the outcome of BHA's Involuntary Commitment Stakeholders Work Group, which was convened to advise BHA on the need to define danger to self or others in Maryland law to ensure both statewide consistency of application and that people in desperate need of hospital care would not be turned away or released prematurely, as they so often are today. BHA will soon be presenting a report to this commission purportedly based on the deliberations of this work group, which I was grateful to serve on. You may recall at the last commission meeting, you heard from me and many Maryland families who were distressed at the clear signals coming from BHA that they did not intend to include in the definition of danger to life or safety language, making clear that an individual at risk of suffering psychiatric deterioration that is permanent harm to the brain is dangerous to themselves. You will recall the testimony of these many parents and siblings that the tragic outcomes suffered by their loved ones could have been avoided had only they been able to get help on the basis of psychiatric deterioration. Since that last meeting, BHA has distributed to the work group a draft of the report they intend to send to the commission later this month. And I regret to report, as others have, that for one thing, it's not going to include psychiatric deterioration language in their proposed definition of danger. And secondly, the BHA is recommending that the definition of danger be promulgated by health regulation rather than enshrined in statute. And I'd like to make clear that my sadness over this goes far beyond not getting the result that I and others had hoped for. Compounding the frustration is that the draft report leaves those of us calling for a psych deterioration standard feeling unheard. The report quickly dismisses psych deterioration as a proposal to authorize civil commitment of non-dangerous individuals. But what we have argued is that an individual at risk of psychiatric deterioration in the absence of timely treatment represents a danger to their own life or safety. We base this argument on copious research demonstrating that extending the duration of untreated psychosis results in physical brain damage and significantly diminishes an individual's prospects for mental health recovery. And our contention all along has been that an individual who suffers such harm due to non-treatment is categorically less equipped to maintain their personal safety and avoid life-threatening hazards than someone whose brain function was preserved through timely treatment. So with respect to Dan Martin's comments, the idea here is not to predict future danger based on current loss of brain function. It is to identify that loss of brain function as a danger in itself, something to rescue a person from, and there's nothing speculative about it. Now, if BHA rejects this line of argument, their report should at least engage with it and explain why it's been found unpersuasive. Instead, the draft report constructs and easily knocks down a straw man by framing the case for psychiatric deterioration as being untethered to any concern for the danger to self or others. Similarly, BHA's explanation for recommending a definition of danger by health reg rather than statute does not engage at all with the arguments advocates have put forward as to why a statutory definition is needed. I know I'm kind of running over time, so I won't go into that in any greater detail, but I'll just say that among the arguments for a law rather than a reg that BHA does not engage with is the simple fact that a civil commitment standard must be interpreted by many outside of the clinical realm, such as police officers and judges, who are much less likely to take note of a health reg than a law. So for these reasons, I sincerely hope the commission will look beyond the forthcoming BHA report and recommend that Maryland recognize psychiatric deterioration as a form of danger to self and enshrine this standard in law, not in regulation. Thank you.
Thank you. Evelyn Burton. Ms. Burton, you may be on mute.
You're muted, Evelyn.
Okay, all right. Is that better?
Yes.
Okay. All right, I'm sorry, I'm not super prepared because I've been working with a family member who has a psychotic individual in a hospital and they're refusing to take him to a commitment hearing because all he has is psychosis and hasn't hurt anyone yet. However, I'll do the best I can. And I want to thank the Lieutenant Governor especially for his clear and strong interest in helping families overcome these barriers to care. We are extremely disheartened that the proposed danger standard language, once again, the process seems interested in compromise and not solving the problem. of barrier to care for families. Never once during the whole process was a proposed standard looked at in terms of the many, over 30, I think, family testimonies that I submitted to analyze, does this danger standard help these families? And in many cases, it would not. And even when I pleaded with them to look at the case of the Logan family, whose son was psychotic, turned away from the ER, even though they said he needed hospitalization, he refused. They couldn't put him in because all he had was psychosis and ended up killing 2 sheriffs. That was greeted with silence. There was no consideration. And by refusing to put in psychiatric deterioration, they're basically condemning these people to a life of psychosis. I'll just mention this one family. The individual has now had, in a course of 8 months, 17 emergency department visits, 2 crisis evaluation center visits, 11 hospitalizations, most of them voluntary, but refusing to take medications once she's in there, and still experiencing psychosis, and never once met not only the current danger standard, but would not meet the proposed danger standard. And this has resulted in 115 days of various hospital stays in the past 7 months at a cost of over $200,000. And one of the arguments the department used for not putting in psychiatric deterioration was the system couldn't handle it. Well, the system can't handle refusing to take these people to a commitment hearing, get them the proper medication, and get them on the path to recovery. This individual had previously, many years ago, been hospitalized involuntarily, given the right medication, and for 12 years was stable in the community. But that's not happening now. So all I can say is that, the process is the same as it's been. There's all these groups who aren't dealing personally with the issue, and they don't see the problems. They're not willing to listen to the families. They're not willing to look at the testimonies. And yeah, maybe it's a little better than what we had before, but it's not addressing and solving the issue. And I agree with Mr. Stenton that, especially after this experience, I would like to see it in statute. I feel very uncomfortable with just regulations after seeing this process, that it could be changed every year on the whim of the administration. My families want to be able to sit down with legislators and talk to them and tell them their story and get them to understand the agony and hardships that families are going through. They can't do that with administrators who are not responsible to the families. So I could go on about a lot more, but I guess maybe that's enough for now. Thank you.
Okay, well, thank you. And we do have legislators on this commission, and they are all free to write legislation. So that is something as well. But it won't be picking up until January.
Yeah, but I guess I would urge this commission to look at that report and make your own decisions, and hopefully consider including the psychiatric deterioration at a minimum on your recommendations to the governor.
Well, thank you. I didn't have anyone else signed up. I don't know if there's anyone else in the room or anyone else who's coming in. Any questions or comments from the commission? I'll take the liberty of pointing something out that I saw in the Washington Post over the weekend. And Dr. Jones, you may have seen it, that Virginia is closing a number of their forensic, not closing to new admissions, a number of their forensic hospitals because of staff shortages. Are we seeing?
No.
Approaching that?
No, and we hope not to. No, they're having a lot of problems with aggressive behavior in the state hospital systems, and that's people are feeling unsafe because they have been unsafe. And so people, I think they had 104 people resign over 2 weeks. And so we are not seeing any, we do closely monitor levels of aggression in our hospital facilities, and that is not going to be not work because we're not seeing any increase in that sort of behavior in our hospital because they are they're staffed. I mean, there's obviously opportunities abound, but that's not an issue that we're dealing with. We are trying to make sure that that people have what it is that they need to continue to provide services and provide care during this time.
I just wanted to bring that up because I did see that, and it was shocking to see their facilities that are closing because of this.
Yeah, I think it's 5.
Okay. Yeah.
That raises another question. Do we have a most recent assessment of the availability of professional staff and opportunities? Because I think one of the things we've heard today, I mean, we can put the best system in place, but if we don't have the staff to staff the crisis beds to be able to provide the more intensive care that may be required, is that going to be an issue going forward?
So the behavioral health workforce is strengthening. Is there a sufficient behavioral health workforce? I don't think that any of us in the behavioral health space would say that the workforce is as robust as we likely need it to be. There's opportunity there. We certainly are doing more to provide scholarship support to help increase interest in the behavioral health fields. We are providing support through growing our peer recovery specialists workforce and also other providers as well, working also with other professional schools, not just I think right now it's a school of social work. I think there's also some school of nursing. So we are working to try to support and grow the behavioral health workforce, but that's been a long-standing issue.
Right, I know on the shore, we were trying to get a child psych unit. We do have no child psych services inpatient in our facilities, and I know Tidal Health has a unit ready to go, but to date, they've not been able to get a child psych. So, I mean, that there are less services now than I've seen in many years. In my career, I've been in psychiatric work and worked in the state hospital for over 40 years. And it seems to me we have less resources now than before. So I'm just concerned that if we want to have a state-of-the-art system, we really need to be focusing on workforce and have a concentrated effort in how to recruit. I mean, we're trying to recruit just CNAs to get people in, to get high school and young adults into the field of health. But then how we get folks to begin to branch out and specialize into the upper level services is where I'm concerned.
Dr. Trippiani, you talked a little bit about the workforce issues, particularly the psychiatrist side. I guess I just could say the same thing, that we're not seeing as many people going into psychiatry.
We never have. Psychiatry has always been one of those fields where very few people choose as a career. And I'll let Dr. Trippiani comment. So I'll let you comment, and I'll make comments after that. Is there something that you wanted to share?
Can you hear us? Okay.
Hi, Lieutenant Governor. Are you asking me to comment on the psychiatry staffing?
Yeah.
Yes, unfortunately, this has been a nationwide problem, not just the problem in the state of Maryland. And especially even within psychiatry, the biggest challenge is to find psychiatrists in the child psychiatry because of the length of the training and the fellowship, in additional 2 years of fellowship training and the hardship that I guess involves related to the training. We can hardly find any child psychiatry, which unfortunately impacts the mental health care of the children and the adolescents who are most vulnerable due to mental health issues. And we find it also very difficult, even within our organization, to be able to recruit and retain psychiatrists because of this nationwide problem at this point.
And so you look at, so you can't turn over, you can't just create doctors just like that, so, and that's where it becomes important to look at the entire workforce and that collaborative care and really giving general practitioners, which is where most behavioral health patients are in now, but giving them the supports that they need to effectively manage treatment. And that's where you look at measurement-based care so that you can, effectively monitor someone's progression through their course of treatment and make adjustments and or referrals so that you really are saving the psychiatrist for those who really need to see a psychiatrist, as opposed to someone who could be effectively managed by their primary care doctor or who could be stabilized by their psychiatrist. Because when I went into psychiatric medicine, which didn't feel that long ago, but it's been a little while, psychiatry was seen as a specialty, at least the way that I was educated, is that, you send someone to a psychiatrist to get them stable, and then they're supposed to go back to their primary care doctor. Otherwise, psychiatrists get full. Well, what we're seeing is that most people who see the psychiatrist, they never transition back to their primary care doctors. The psychiatrists are limited in how many people they can see. So having a different model of using collaborative care and really helping people to looking at creating that hub and spoke concept for behavioral health will increase the bandwidth of the number of people that psychiatrists can treat.
I know in Lake Shore, many of our counties are now putting together teen mental health initiatives or its groups who are looking at the resources in the county, because we've seen an increase in teen crime, and then we don't have enough resources to be able to do the assessment and early intervention. And so what we're having is kids coming in, committing crime, going back out again, and it's gotten to be a pretty intense run out the door. Unfortunate situation, but I think in the pandemic it's aggravated it. So we're getting a lot of information across the board that we're having increased anorexia in our youth population and other issues that are going to have to be addressed in the future.
A number of people have called it kind of the tail that's in the time period, tail of the pandemic, because it's something that's going to continue once the pandemic is ended. It's just like a flu, but we're still going to be dealing with the repercussions on the mental health side.
You've only just begun.
Yes.
Senator.
I'm not sure if this is for yourself or for Dr. Jones, but it seems like this workforce issue cuts across all four of our subcommittees and all of our counties. And so I just wonder if, given the increased need in mental health right now, if there's anything going on at the state level to really take a deep dive into the workforce issue. Because I recall that there were several bills looking at scholarships and nursing and therapy and different things, but I haven't seen a list of recommendations on what the state should be doing to increase, providers in this area. And it might be both a short term, like what do we do kind of in crisis mode coming out of the pandemic, and then longer term, how do we get people into these long-term jobs? But just curious if anybody knows if there's anything going on to address the workforce need at this point in time.
I have to go back and look and talk to on our higher education commission would be one angle, but also like for some of the areas that are more healthcare workers, not necessarily full professionals, but on the apprenticeship programs, but the Department of Labor's is there apprenticeship program? Earn program. I think we have medical.
They do.
They have medical, yeah, the CNAs, but that's, that's the start of that group. But you're right, there needs to be more encouragement. I don't know if there are scholarships for nursing.
Or
I
something.
know there's been a lot of
There can be,
initiatives for it.
yeah, the work for, I know we learned in our economic regional councils that there's quite a pot of money coming down from the federal level into workforce development, so that we were thinking about our community health workers as a way to get entry into a lot of the minority populations, the Haitian population, so that we can begin to grow indigenous workers and start with the community health workers because of the resistance to the vaccine. So there is money available that can be used down through the counties that would, you can either train the trainer and reimburse those folks, and people can get paid while they're taking that training to be able to develop it. So at least on the shore, we have those funds, and I'm pretty sure it's around the state. So I think if there's a way we can kind of pull all of that together and focus it and make some recommendations at the local level, or the local communities can follow that up to be able to coordinate it and add a little extra push to it and inform people about what's going on, and then have some more incentives.
I think there could also potentially be some scope of practice issues that could be looked at, like any other medical profession specialty, whether it's dentist or optometry. From time to time, we look to see, could we be doing things more efficiently by giving a greater scope of practice, particularly for fundamental or routine issues, to a psychologist versus a psychiatrist or a social worker? I think it's, I know it's a controversial subject, but it's definitely, given the shortage and the crisis we're in, worth examination.
That's a good point. I mean, I think the state has already done that with registered nurses can do more things than some other states allow them to do. Sometimes the physicians didn't like that, but they've all dealt with it. And so I'm an expert on that, but it's worth taking a study.
Other states use a lot of advanced practice nurses, but specialists, and those practitioners that kind of focus in psychiatry. And we have that here. Yeah, we do a lot of that. Embedding and as we move forward, I think one of the optimistic initiatives on the horizon is working in the interdisciplinary model in the community. That's the benefit of being in a facility and working, because you have Title 10, which is inpatient psych, requires, a doctor, nurses and social workers and nutritionists. You get that coordinated team, and we have a lot of practice initiatives around that teaming that I think will make a big difference moving forward. And it also provides that kind of creative opportunity for multidisciplinary training and education. I better watch my mouth. That educational opportunity and clinical opportunities where the disciplines can work together. And I think that will make it more efficient, but that's kind of new on the horizon that the department I know is working on. Or get some initiatives out of the Community Health Resources Commission. We could certainly ask for that.
And not to diminish anything, particularly the testimony that occurred, but maybe each of our subcommittees can take a look at this issue of workforce. As Senator Tester said, it does cross all these areas, that maybe that's something that we think about it in terms of any type of recommendations that we discuss. And they bring in, one members from different boards, the pushing board, the petitions forward, talk about these areas. So social workers, I think there's a social workers board. There's so many boards and commissions, but I think there is one of the registered social workers. Talk about what their capabilities are that may not be utilized as the delegate said. Kim, we brought to bear the multidisciplinary.
And I bet not many people ask them to come in and tell us.
Tell us what you do.
Tell us what you do and how you see it and what you think might need to change. What kind of either regulatory relief do you need? What kind of barriers do you see? How, because they're working.
They're often, right, and they're talking amongst themselves.
There's some issues with, like housing. It's hard to get housing if you have certain degrees of the felony. You can't, it varies from place to place. There's a federal issue there. There are some issues we probably will, working with the Board of Nursing because of the degree of violations that you have as you, with the impaired nurse program. And all of those issues may be helpful for us to hear as it impacts recruitment and retention of our workforce.
With that, we're to the end of our program. I'd like to thank all the commission members, of course. Joe, thank you for the presentation. Mr. Joe, thank you for the presentation. Thank all those who testified. They're all recorded. Everything is taken very seriously. And thank everyone for being part of this and asking to continue to be part of this. You all are heard, even where we disagree in places. Everyone is being heard. So thank you again for everything. And our next meeting, September 14th. It's Tuesday, September 14th. We'll get information out. We'll put up the minutes to this meeting in the coming weeks. But Tuesday, September 14th from 4 to 6 approximately is our next meeting. And anyone is free to submit any type of comment or testimony to email address mbh.commission@maryland.gov. That's Mary Beta Henry.commission@maryland.gov. Thank you all.
Thank you.